and we're going to talk about testosterone replacement therapy, the risks and benefits, which has been kind of a semi-hot topic in the past few years because of the risks that have been strewed to it. Okay. So as you know, testosterone is the major androgen in men, both in concentration and its activity. It's an anabolic steroid, a performance-enhancing drug, a Schedule III controlled substance. But maybe what you don't realize, although probably in the back of your mind you do, that the use of it has quadrupled since the turn of the century. So in the last 14 years, actually, it has quadrupled in use. But the question is, has it been used appropriately? Is the right population using it? Because even though the use of it has gone up, and that's probably primarily due to all the advertisement, and you'll hear it, you'll see it on TV, you'll hear it on the radio, see it in the papers. That doesn't mean that everyone who is hypogonadal is using it. In fact, some of the papers say that only about 1 to 2% of men who could really use it aren't using it. So who is using it? Well, first of all, I think that paper that I read, that sounded really low to me. But it was definitely a good paper. But the people who are using it may be those who are looking for it for enhancement and for bodybuilding. And so that's not what this is all about. It's not for performance enhancement or bodybuilding. Those things certainly can happen with it, but we have to wonder whether or not the right population is using it. So who's the right population? Those who are symptomatic from hormonal deficiency. And the reason why I say that is because there are people who may have low testosterones and are not really affected by it. So these are not people who need to be treated, unless they're having some bone mineral density problems or things like that. So testosterone deficiency syndrome. So syndrome is the key word there. Clinical or biochemical syndrome associated with advancing age and characterized by typical symptoms and deficiency in serum testosterone levels. So it's a syndrome. It's not just a matter of having low testosterone, but you're having symptoms along with it. So it's a syndrome. And it's commonly referred to the past several years as andropause or male menopause or androgen deficiency in the aging male, otherwise known as ADAM, late onset or adult onset hypogonadism, and that actually is the most common form, or currently the most popular is low T. Hey, everyone talks about low T. It bothers me that the advertisements for it are really giving the wrong message. The latest one that I've heard, and this was only 3 weeks ago that I first heard it, was on the radio, and it was calling all men who, do you remember when you were young and you used to party all night, and now you can't? Have you heard that one? Now you can't party all night, so do you want to? Maybe you need testosterone, maybe you have low T. Wow, what kind of message is this sending? I want to party all night. Well, even if I could now, I don't think I would. But there are people out there that may feel differently. So low T, I think this is what they're trying to get across. Be this powerful macho man and do all kinds of things. Hopefully, he's saying not me, but hopefully there are men out there who aren't built like this who are saying not me also. But that depends upon us as far as patient education. There are two distinct roles of testosterone. One is androgenic and the other one is anabolic. So the androgenic part takes care of the prenatal differentiation, the effect on the reproductive tract, secondary sex characteristics, libido, erection, ejaculation. The anabolic, the growth-producing effects on somatic tissue, bone formation, the erythropoiesis, the prostatic growth, and muscle bulk. The role of testosterone during the life cycle. Well, during gestation, it works to help with the male differentiation. And that's the 7th week of gestation. We have testosterone being secreted from the Leydig cells, and that develops the vas deferens, the epididymis, seminal vesicles, and masculinizes the external genitalia. Then it's fairly quiet, testosterone, fairly quiet until puberty. All right, then you have virilization taking place. So definitely bone growth and epiphyseal closure. All right, then you have laryngeal enlargement and vocal cord thickening, changes to body masculization and fat distribution, testicular growth, and initiation of spermatogenesis. So we see how this definitely happens in the awkward teenager who's undergoing it, but this is what's happening. In the adult, the role of testosterone is to sustain the spermatogenesis, maintain muscle bulk, maintains the secondary sex characteristics, and aids in erectile function. The hypothalamic pituitary-gonadal axis helps with the testosterone regulation. So the gonadotropin-releasing hormone is secreted by the hypothalamus, and that stimulates the anterior pituitary to release the gonadotropins, the LH, the FSH. The follicle-stimulating hormone stimulates the Sertoli cells in the testes to produce sperm, whereas the luteinizing hormone stimulates the Leydig cells in the testes to actually produce the testosterone. So metabolism, the testosterone, some of it converts to DHT, dihydrotestosterone, and that is actually like the workhorse of testosterone. So when we think about all the masculine things that are happening, that's coming from the DHT, all right? And some of it converts, it gets aromatized to estradiol, okay? And then what happens with that is that's active in the brain and in the fat and liver and the testes, whereas the DHT is active in skin, liver, and prostate. So the DHT then gives us the male pattern hair and prostate growth, acne, et cetera, all right? The estradiol then causes bone resorption. It causes HDL/atherosclerosis, that whole effect, and it also has brain and breast effects. The problem with the estradiol is that the more that you have fat cells, the more estradiol is produced. The more estradiol that is produced, the more fat cells you'll have. So it's a vicious cycle. So that's why with a lot of estradiol on board, it's very hard for men to lose that weight, and a lot of that weight is the weight that's around the middle. When we talk about low testosterone or hypogonadism, there is primary, secondary, and a combination. So when it's primary, what we're talking about is something that's directly affecting and coming from the testes. And that's the aging, the late onset or adult onset hypogonadism is considered that. Cryptorchidism, infection, trauma, chromosomal abnormalities like Klinefelters, and orchitis like from mumps, chemo or radiation therapy, all these directly affecting the testes and the production of the testosterone. It's considered secondary if it's not from the testes. So think of it that way. So if it comes from some other gland, like the pituitary isn't doing its job, then it's secondary. So that's considered to fall into that category as obesity, the pituitary disorders, Kallmann syndrome, uremia, Cushing syndrome, things like that. Now, in reality, low testosterone is actually many times a combination of the two. both primary and secondary. The easy way to consider whether it's primary or secondary is to consider the gonadotropins. So there'll be low T whether it's primary, secondary, or combined. But if it's primary, the gonadotropins, the LH and FSH, will be elevated. The pituitary will be trying to get those testes to work, but the testes doesn't take it up. So it's the testes that's the problem. So it's primary. In secondary, again, low T, but you'll have a low or normal FH, FSH, and LH, all right? Because the pituitary is doing its job, but it's the spermatogenesis within the testes that is impaired. So the combined is low T, a variable LH and FSH, and impaired spermatogenesis. About 13 million men have hypogonadism, and that ranges from age 30, I should say first, from age 30 to 35, there's a 1, even 2% decrease in testosterone every year. 40% of men greater than 30 will have a testosterone of less than 300 at some point. But as I mentioned before, that doesn't mean that everyone will have symptoms. The late onset or adult onset hypogonadism, again, is the most common form. Now, the reason why it's such a big business and we hear all this advertising about it is we all know that most of our population now is older. So since we have a very large older male population, they can sell a lot of testosterone if they're good about it. Men over 65 will have a 2 to 3 times likelihood of having a low T than younger men. So the signs and symptoms that we usually look at when we talk about low T or hypogonadism or the testosterone deficiency syndrome. Low libido, erectile dysfunction, irritability, mood disorders, anemia, sleep disorders, weight gain, loss of muscle mass, fatigue, loss of energy. So we all know the list of things that they can complain about that might be due to a low T. Okay, so many of these, though, are nonspecific. And that's why, although it may be easy to diagnose deficiency in testosterone, you don't really know if that's the cause of what you're looking at symptom-wise, because these are so nonspecific. Some of these symptoms can be really due to other issues. So there's a lot of differential diagnosis that could be applied. Testosterone deficiency is associated with poor general health. So if you're looking at, someone comes in and they have diabetes or metabolic syndrome, they have cardiovascular disease or sleep apnea or, osteoporosis, all these things might register, I wonder, because then he has some complaints, I wonder if it's one of these, or have these triggered or caused or just associated with them with a low testosterone. As far as osteoporosis, and I did not see any evidence why this happens, but men globally do much worse with osteoporosis than women. All right, the big thing associated with it is age, that thing that creeps up on all of us. All right, so 31% of men over 45 years of age will have hypogonadism. 50% of men over 85 will have hypogonadism. So it gradually goes up the curve from the younger age to the older age, but it's always happening more. The overall prevalence, I have written there is 38, but literature has anywhere from 38 to 42% of men who have hypogonadism. So the patient assessment, part of what I already said, look at what their existing comorbidities are, and they may tell you that they are indeed a candidate for or at risk for having a low testosterone or a testosterone deficiency. Also, long use of opioids can cause it, or a high use of corticosteroids, like someone who has asthma, that can also cause it too. So you have to have that, and you suspect low T if they have one or more of the symptoms that we have gone over. So it's the combination. So this is a syndrome that we're looking for to treat, all right, not just one or the other. And the other thing is, and I did mention it briefly, is that before you treat anybody, you have to consider his level of bother. Does he have a low T, but he feels fine, he's not bothered by his somewhat lowered lack of libido, or it depends upon what the symptoms are and what their bother score is about it. Now, as far as the existing conditions, you see that I have obesity in all caps. And that's because obesity is the single most important, powerful prediction of having a low testosterone. So it is the most common cause of low T, second to aging. All right, so that should be easy enough, maybe, just lose some weight. And well, how hard is it to lose weight? Most of us know how hard it is. But even a weight loss of about 20 pounds can change the testosterone level to a noticeable degree, to a satisfactory degree. So the key here is that, again, patient education, and have them understand how it's all linked together. If they can lose at least 20 pounds, they may see a world of difference in their symptoms. We know that it's hard to lose weight, but since we're talking about mainly late onset, adult onset hypogonadism, what happens is we have so many other comorbidities that may interfere with them exercising to lose weight, etc. So it is a very real issue that it's hard to lose weight, but it's something that we definitely have to investigate with them about if they're motivated, if they can, and what the benefits would be if they do. The tests that we look at to diagnose the testosterone deficiency. So when we do the testosterone level, we can't just base it just on one. We want to have at least 2 low readings. And the testosterone level, as you probably already know, should be drawn in the morning because that is the time that it's the highest. There is a diurnal variation. So, and even a young, healthy male will have a low testosterone at some point during the day, or very well can. So you just want to be sure that there are morning samples of the testosterone. This is total testosterone that I'm talking about. You can also test the free or bioavailable testosterone, which is generally about 1 to 2% of the testosterone. The rest of it is protein bound. I can also test the FSH, the LH, the gonadotropins, estradiol, prolactin, or thyroid studies. Now, if I'm suspecting that it's a thyroid issue, then it's usually not something that I'm testing. But what happens is by the time the patient comes to a urology clinic, this is something that his primary care doctor has already looked at. If it wasn't, and I do order them, and if I see they're abnormal, then I would then send them to endocrinology. In fact, in the VA where I last worked, a lot of the testosterone was given in the endocrinology clinic rather than the urology clinic, whereas the VA that I worked before that, most of it was given in urology. Testosterone levels will also vary upon that patient's point in life. And so I found this very interesting. It depends upon what his relationship is. So if he's unattached and he's looking to partner, his testosterone level will actually be higher because that gives him more oomph, more aggression to go out and look for someone. And the same thing is true if he's looking to father. So if he's fathering or in the process of, or partnering or in the process of, the testosterone levels will be high. Once that partnering is established and or once that fathering is done, then the testosterone level actually drops down. And you would think that, well, maybe it's just so that less aggressiveness, smooth relationship with the partner, better fathering. The normal lab values are all listed there. One thing that I want to point out, and one of the problems with testosterone testing, is that there is a difference from lab to lab. So it depends upon what lab you use. All right, but typically you can say normal is from 300 to 1,000, but there are many labs that go higher than that. Generally though, if it's less than 300, it's considered to be low.